EKG of the week. Welcome to a new segment that we're doing with EMS Grand Rounds. The idea is that we're going to do some hopefully relatively brief videos just walking through interpretation of EKGs. And the reason for that is that EKG interpretation is probably the thing that you do as a medic that really sets you apart from most of the other, certainly pre-hospital healthcare levels of credentialing or certification or licensure, but probably also a lot from most other healthcare professionals. I mean, who else out there is really interpreting a 12-lead EKG other than physicians for the most part? So real interpretation of EKGs. The problem is, though, that we give you about 2 weeks of cardiology in medic school, and then we really never come back to it. And when's the last time that you actually walked through an EKG and had somebody tell you, yeah, this is this, this is this, this is that? Probably not real often after school, right? Because who's going to know that, generally speaking? So the idea is that we are going to walk through how to actually interpret an EKG, and we're just going to start with some of the basics, and we'll try to get into all the pathology and stuff, but this is just how to go through it. We'll try to stay out of some of the weird kind of stuff, and this isn't designed as a master class. This is just repetitive reading so that you can learn to go through the essentially algorithm and maybe come up with like a differential of what it might mean. Are you going to use all these? Are these real common? Are they going to necessarily change your practice? No, not all the time, but it is something that you ought to be able to do. So let's talk about this here skill. So we'll start off each time looking at an EKG, and feel free to pause at the moment and see if you can interpret this one. We are going to go through it, though, in sort of a systematic manner so that we don't miss things, because everybody can just look at an EKG and like, okay, well, blah. But are you really hitting all the parts? So the way that we're going to walk through this, we're going to start with rate. We're going to look at the rhythm for each EKG. We're going to look at the axis, although if you had to skip axis is probably the thing that I've never actually used to do anything important. I think all the rest of them I probably have. But anyway, we'll talk about it because we're talking about reading EKGs. We're going to talk about intervals and blocks. Then we're going to go through and look for signs of ischemia and infarcts. And then general pattern recognition like hyperacute T waves or peak T waves or like needle-like Q waves or the Brugada stuff or all that kind of things. Just some patterns that you have to know. And then we're going to come up with a final impression. So rate, rhythm, axis, intervals, blocks, ischemia and infarcts, patterns, and then come up with an impression. So let's go through and look at this one. So to start off with, here's a standard EKG. Again, you can pause it if you want and take a look. But otherwise, let's jump into it. Rate. We've got a couple ways we can determine a rate. One way that people tell you to do it is to look at the interval between like peaks. So essentially we take this R wave here and we go how many blocks is in between the next one, and that will give us the rate, because if it's one big block, that's 300, and then another one is 150, and then the next one is 100, and we see that this one is right on that line. It's about 3 blocks, so right around 100 or so. That's one way to do it. The other way to do it that I like a little bit better is I know that this is a 10-second strip that I have printed off here. So I can just count the number of QRS complexes in that 10-second strip and then multiply by 6 in order to get the number that are in a minute. So let's start at the bottom. And the rhythm strip is the easiest place to do it, but you could do it on any of them. But anyway, I like this one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, and just a little bit more, but right around 16. So 16 times 6 gives us mental math 96, thereabouts. Let's see if we're close. Yeah, that's what the computer tells us as well. So I like that second method because it gives you the true number of beats in a minute, or at least the true number of complexes in a minute. Whereas the other one, if it was, if this beat and this beat were actually really far apart, like in AFib, but this beat and this beat were real close together, depending on which one you measure, you could get an EKG, or you could get a rate of 150, or you could get a rate of 80. So I like that one at the bottom. Counting across and then multiplying by 6 myself, but you got to kind of know how to do each one at least a little bit. Anyway, that's our rate. How about the rhythm? Let's look at the rhythm now. Is there a P before each QRS complex, and does each QRS complex follow a P wave? Let's see. Let's just look here. We see P before that QRS complex, P before that QRS complex, P before that QRS complex, P, PQRS, PQRS, PQRS. And we're going all the way through, and we see distinct P waves, and we don't see any QRSs that happen without a P wave, and we don't see any P waves that don't have a QRS following it. So we're going to call this sinus rhythm. Rate 96, rhythm, sinus. Let's talk about the axis for just a second. And again, if you had to skip something, I usually make it axis because it doesn't really influence the way that I think about EKGs. But just for the sake of doing it, let's talk about axis real fast. You may have run over this before. It's sometimes a little bit difficult to kind of conceptualize. Let's hit it real quick. So you have electrical energy that goes through your heart, and it normally starts kind of up here somewhere in the top on our projection here on the top left, and goes across the heart and then down towards the bottom right. The axis is the main direction of the electricity that flows through your heart, and it generally goes, again, from, at least looking at it, from our top left to the bottom right, or from the patient's right, essentially right arm, down towards their left leg, something like that, or the left side of their chest, left side of their upper abdomen, something like that. But it goes somewhere like that, top to bottom, right, patient right to patient left. And so a normal axis, the main direction of electricity that flows through the heart, stays in this green area here from 90 to negative 30. Now we can use the leads on the EKG to figure out what direction most of the energy is going. So again, if something is positive in a lead, that means the direction is flowing in that current. The ones that we usually use to determine this green area are lead 1, which is this guy right here, which goes essentially side to side, horizontally, something like that. So if the complex in lead 1, if the QRS complex in lead 1 is above the baseline, it will be over on this side. If it is below the baseline, lead 1 is positive over here, it's negative over here. If it's above the baseline, it's going in this direction just by convention. So this is positive lead 1. And so if the complex is positively in lead 1, that means that the axis has to be somewhere over here in this area, because this is the positive side of lead 1. Now, that's only enough to get us sort of narrow off half the circle. What about the rest of it? We can look at lead AVF, which essentially goes top to bottom, up and down. And positive is on this, really what you would think of the lower part. Negative is what you would think in the upper part, essentially. So lead 1 makes essentially the 0 line, positive down here, negative up here. So if the QRS complex is mostly above the baseline in lead AVF, that means that it must lie somewhere down here. And so when you put those two things together, if it's positive in lead 1, we know it has to be on this side of this line. If it's positive in lead AVF, then we know it has to be on this side of this line. And if they are both positive, then we know it has to lie somewhere down in this corner here. Now that's cool. You could leave off that for the most part and just say that for the most part, that's going to get most of it. However, there's this little triangle up here. So we could actually add in a third line just to see, again, just to clarify that a little bit. This is essentially the 0 line. What is the line that crosses that? It's lead 2. So lead 2 is positive down here, negative up here. And so if it is positive in lead 2, it has to be somewhere on this side of the line. What that means is that if we put them all together and we want to get in this green sort of third of the pie here, if you're positive in lead 1, that means you're over on this side. If you're positive in lead AVF, the QRS is mostly above the line in lead AVF, it has to lie down here. Or if it was, say, negative in AVF, that doesn't necessarily mean that it's on the wrong spot, because you could still have this little tiny triangle. If it's negative in AVF, you could still have it be positive in lead 2 and end up in this little triangle here. Cool, makes sense? Maybe not. Axis is hard and, again, not terribly useful for us in the emergency setting, generally speaking. But why might it be useful? Well, if you had a whole bunch of, if for some reason the axis was pointed over this way, why would that be happening? Because, maybe you have a bunch of kind of dead or dying tissue over here in the left ventricle, and so the electricity is moving that way instead of over here. Or maybe the electrical signal is, I don't know, coming from up here for some reason and going that way. that may make a difference. Again, for the most part, I tend to not use axis and more or less skip it, but that's the down and more in depth than maybe we want to look at. But we're going to say that for the purposes of this program, we're going to use lead 1, we're going to use lead AVF, and then we're going to use lead 2 as the discriminators for what the axis is. All right, enough of that. So going back again, rate 96. Rhythm, we said, was sinus. Axis, we look here and we see that it is mostly positive, or at least maybe isoelectric, meaning it sort of splits lead 1, but we'll say it's, for the sake of argument, mostly positive, mostly above that line in lead 1. If we look at lead AVF, so we already know it's got to be towards the right side of that, our right side of that circle. We're positive in lead AVF, so it's got to be on the bottom half of that circle. So we know we're already in that good quarter, but just to clarify as well, it's positive in lead 2, which means that we're going to end up somewhere in that somewhere in the normal axis. Let's just call it normal for the moment and leave it at that, and you can just forget the last, 3 minutes or so. All right, how about intervals, etc.? We did rate, rhythm, axis, intervals, and blocks. Let's look at our intervals. The intervals, the 3 that I look at are the number 1, the PR interval. So the PR interval is the start of the P wave to the start of the R wave, which is this part of the QRS here, the first upward deflection there. Start of the P wave to the start of the R wave. And that should be less than one big box. And so let's see if that's the case in this EKG. It looks like, again, here we are. P wave kind of starts there, about this little line right before the thick line. And does it finish and the QRS complex starts? Does that happen before 5 little boxes or 1 big box? Yes, it looks like it does. So I don't even have to know the true number of it. I can just tell you that looks like a normal PR segment. You can get short ones too, but let's say there's no PR prolongation in this EKG. Again, the first one I look at, PR segment. How about the QRS? That's sort of the next thing along the line here. Let's look and see the width of the QRS. The QRS width should be less than 3 little boxes. So from the start, let's see, there's sort of 1, 2, and it finishes just before that third little box, which means you have a narrow complex QRS, which we can confirm in other leads here. Again, it goes 1, 2, just about halfway through that other little box there. So this is going to be a normal QRS, or a narrow QRS complex. And that looks, when you look at this, you don't see anything that's big, wide, and fat. They all look pretty normal. So narrow complex QRS and normal P wave. The last one I look at is the QT interval. So the QT interval comes from essentially the QRS complex out to the end of the T wave, and this is dependent on rate, and there's a bunch of other things that kind of influence it. And so there's this calculated QT interval that the computer does for you, which you can look at, and it also changes by age. Boy, this is all confusing, right? Here's the thing that I usually do. Just to eyeball it, I will look at the distance between the two, say, R waves here. So we notice the R wave on the left to the R wave on the right, and then split that distance between the two of them. And then the question is, does the T wave finish before you get halfway between those two peaks? And in this case, if you look at it, it looks like it does. It looks like it's about four of those complexes, and so it ought to finish. If it was going to be long, it would probably finish somewhere out here-ish. But it doesn't look like that's the case. It looks like it finishes before halfway those two. That's the quick eyeball. You're going to have to just look at the thing at the top. You could probably calculate the thing if you really tried or really had a bunch of time, but it's not really important for us. We can go with what the computer reads us in terms of measurement on that one, or the eyeball for the most part. Does this look super long? No, it doesn't look super long. So we have a normal PR interval, a narrow complex QRS, and no PR prolongation. Since we don't have any change in one of those things, we probably don't have any blocks, but let's just go back and look through and see. First of all, we always think of blocks like AV blocks. So are each of the P waves occurring before a QRS, and do they look like that PR interval is changing? No, let's see, that PQRS, PQRS, PQRS. We said sinus already, but we noticed that there's not like, the PR interval. There's no bigger than one big block between the start of the P wave and the start of the QRS. There's no short, longer drop like you might see in a Mobitz 1, or sorry, in a first or second degree block Mobitz 1. There's no randomly drop beats like you might see in a 2, and there's no dissociation that you might see in a third degree block. So we don't see any blocks. We don't see any interventricular blocks. We have narrow complex QRS with no obvious like right bundle branch or left bundle branch block morphology on this one. So rate 96, rhythm sinus, axis normal, intervals and blocks, normal intervals, no blocks to be found. Rate rhythm axis, intervals, how about ischemia and infarcts? Here's where we're going to look at the ST segment, essentially, in the T wave. So we're looking for, first thing I'm going to look for is a STEMI. So I look and just scan down through the ST segment. Is there significant ST elevation here compared to the baseline? And we will say no. Now, you might be fooled in some of these. You got to find a decent looking complex, but I will say that there's not actually more than a box of significant ST elevation here. So no significant ST elevation, no significant ST elevation. And we'll talk about how to really differentiate that later. No elevation. I ignore lead AVR generally. There is stuff you can read in it, but let's just ignore it. No ST elevation, no ST elevation. Going through the precordials, there's lead V1, no ST elevation. No significant ST elevation in V2. You do expect to get some ST elevation in lead V2 and V3, generally speaking, and it's age sort of dependent, but you can get up to 2.5 blocks, 2.5 little blocks, 2.5 millimeters of ST elevation and still have it be totally normal. That's just the way that things look in lead V2 and lead V3. And again, that's sort of age dependent, but we don't see any obvious ST elevation there. How about right here? Does the ST segment start not obviously elevated, not obviously elevated, not obviously elevated there, and not obviously elevated there? So we haven't seen any ST elevation. We can go back through and do the same thing and quickly scan for ischemia, which would be ST depression and T wave inversion. And we see the T waves are generally all upright. We don't see any significant ST depression. So we will say no signs of ischemia and infarct on this one. And no signs of old infarct, which we would go scanning through quickly looking for Q waves that aren't supposed to be there. So Q wave often is an old infarct, something that has taken its time and actually gone on, for like a day or something like that, not like a STEMI. But no Q waves that we see any here, or maybe just a little bit here, but you get a Q wave in your inferior leads sometime in lead 3. Lead 3 is kind of the backwards one, but certainly no Q waves out here. No Q waves here. All right. No ischemia, no infarcts, no old infarcts. Finally, we look at pattern recognition. Any funky patterns that we see in this one, like big peak T waves that you might see with hyperkalemia, or hyperacute T waves where the T wave is like 3 times the size of the QRS complex or something like that. And again, we get into the different patterns and stuff later on as we find them. But in this case, I will say that everything looks pretty much normal, and I don't see any of the obvious patterns that I would be looking for. The one thing I thought I saw a little bit earlier was maybe there's a little delta wave here, like you see that little slur at the beginning of that QRS complex, but it's not real consistent. I thought maybe this was going to be a WPW, Wolf Parkinson White, maybe just a suggestion of it, but it's not consistent. I don't think we see it on this one. So, no obvious patterns to see. So what have we got otherwise? We've got sinus rhythm at a rate of 96, which is lower than tachycardia and higher than bradycardia. We have normal axis, normal intervals, no signs of blocks, no signs of ischemia or infarcts, no patterns. So we're going to call this, our impression, normal sinus rhythm, normal EKG. All right. That took a little longer to walk through than most of them will, and the reason for that is because we're really going to explaining each of these. We'll get faster and faster as we go, as we get used to doing it, but we're going to walk through all these at that same sort of algorithm. Rate, rhythm, axis intervals, blocks, ischemia and infarcts, pattern recognition, and then impression. So I hope you'll tune in for our next episode, our next go-around with it. Like I said, these will be quick little videos, probably between 5 and 12 minutes thereabouts. But like, subscribe, share, do all the stuff for the social medias, because it'll help get the name out there, and it'll help us to be able to make some more of these. So hopefully you like it. Let us know what you think. If you have any questions, hit us up or leave something in the comments. And otherwise, we will see you later. Stay safe out there.